Hi, my name is Zev Wainberg. I am a medical oncologist at UCLA, Los Angeles, California. I'm a professor of medicine and surgery, co-director of the GI Oncology program, and director of the early phase clinical research program at UCLA. Nice to be here. So the question relates to the role of screening for gastroesophageal cancer. And this is a complex question related to what part of the world you live in and where your ethnic identity is from in some respects. We know that in Eastern or Southeast Asia, gastric cancer is the most common cancer that is seen. So there have been for many years universal screening recommendations for patients in China, Japan, Korea, and other Southeast Asian countries because of the incidence of gastric cancer. And there they do a screening routinely. In the Western world, gastric cancer and GE junction adenocarcinoma and esophageal cancer are far less common. And therefore, there have been no universal screening recommendations that have been applied discrete from doing history and physical exams and symptoms. But when I refer to screening, I mean more endoscopic evaluation. Now, we know that there are certain risk factors for people with esophageal cancer and gastroesophageal cancer that relate to their individual characteristics. And by that I mean if they have a long-standing history of reflux disease, of heartburn, of symptoms that are causing dyspepsia and difficulty with swallowing and eating that reflect on continued heartburn, we know that some of those patients are going to undergo changes in the esophagus and the stomach that reflect possible cancer risk in the future. So anybody over the age of 50 or so who has heartburn is often recommended by the gastroenterologists to get an endoscopy, to look at the distal esophagus and look at the gastroesophageal junction, and look for early signs of what's called metaplasia, which is often a characterization used in medical terms as Barrett's esophagus. And Barrett's esophagus is an entity that describes changes in the esophagus that are usually seen in people with long-standing history of heartburn. And if Barrett's esophagus is identified, then those people get more frequent endoscopies to look at that area more carefully. And by that I mean to map out the area, take biopsies if needed, see if we start to see any suggestion of early progression or early signs of precancerous lesions. And in many ways, this is a complicated story because it has to do with, if you do see Barrett's, what do you do about it? That's controversial. Some people do like to give drugs, proton pump inhibitors, like lansoprazole or esomeprazole to decrease the acidity. Some people like to give aspirin, as there has been some studies suggesting that may benefit the risk of going into cancer. But certainly we know that people who are identified as Barrett's or long-standing gastroesophageal reflux or heartburn should have more frequent interactions with the gastroenterologists to look for that. In addition, there are other rare conditions such as pernicious anemia, which is a condition described as being as having a difficulty with absorption, and patients present with anemia. That's a risk factor for stomach cancer. And there's a few others, including family history, such as family history of stomach cancer or esophageal cancer, family history of other gastrointestinal cancers that may require us to be more diligent with our screening. But for a large population recommendation, which includes hundreds of millions around the world, in the Western world, there is no routine endoscopic or doing a endoscopy to look for gastric cancer and esophageal cancer and otherwise healthy patients, which distinguishes it, of course, from colorectal cancer, where in colon cancer we know the incidence is higher, the risk of gain is higher in the Western world, so we do recommend colonoscopies and screening for that disease. This is different in our part of the world where this disease is less common. Keeping in mind that, as I mentioned, in Southeast Asia, everybody there gets an endoscopy at a certain age, or is recommended to get one at a certain age. So an excellent question that is a bit challenging to answer. So the risk of developing esophageal cancer from gastroesophageal reflux and leading to Barrett's is actually quite low. In Barrett's esophagus, which, as we know, is a precursor to cancer, the risk of developing cancer is only about 0.5% per year. So it does multiply over time. And those are in patients where there's no dysplasia. And when someone has Barrett's esophagus, the important thing to determine is there any dysplasia? And dysplasia refers to features of the esophageal tissue that are a little bit atypical looking, not typical what we would expect to see in that part of the esophagus, and may portend a higher risk. So for people without dysplasia, it's about 0.5% per year, which is very low. 1 out of 200 of those patients will develop cancer annually. And for Barrett's esophagus with dysplasia, the risk is slightly higher, although not clearly defined. And that's what's called low-grade dysplasia. Now, people with long-standing heartburn don't always go through that progression from heartburn to true Barrett's to cancer. There are unfortunately a lot of variables here, and some people never get a diagnosis of Barrett's and unfortunately present with cancer of the esophagus. But the important thing is that, everybody who has any element of heartburn or longstanding reflux or some Barrett's should be entered into one of these screening programs, because the risk is there and we want to prevent that risk. And the other thing we can do to prevent that risk is, in patients with Barrett's, should be on a proton pump inhibitor, because it does seem to reduce the risk of developing cancer over many years. And that includes drugs like lansoprazole, esomeprazole, and others, omeprazole, that have all been shown to reduce the risk by reducing the acidity in the stomach and esophagus to developing true cancer. So important thing is to screen these patients if they're identified, make sure that we have done the right mapping out of their esophagus to know what their risk is, and act accordingly.